Can you all believe we have come to the end of perhaps the best meeting in the area of DEI and ADRD? It's just impossible to be here. And how much have we learned? But before we do that, I want to applaud Dr. Morris and his team for organizing a spectacular meeting. Thank you. I know he and his team have been working for over a year to get this meeting going, so thank you again. Well, if you take a step back and think where we were just 2 years ago when Dr. Morris organized this meeting in the area of DEI and ADRD research, we have learned so much as a field. There is a concerted effort ongoing across the country and beyond in understanding how different races and ethnicities will affect the disease biology. In fact, it affects the whole spectrum of the ADRD, right from the biology to clinical presentations to biomarkers to eventually deciding how a person may respond to emerging treatments and prevention strategies. We heard so many new data here that will be published, and that really will form the basis for us to proceed in understanding how we diversify our cohorts, how critical that is, and also understand how it affects the biology of the disease. So what I'll do today is, like yesterday, I will just present a brief summary, some of the key points that I thought were there from each presentation, and then I have a slide where I have a collection of some incoherent thoughts about what things we may think more than what we discussed here today, and I would love to have your opinion, and perhaps we may proceed on one of these areas as a field. So let me have the first slide here, and again, a reminder, why is DEI so critical for ADRD research? And I went through it yesterday. In my opinion, it really leads to a better understanding of the heterogeneity of the ADRD neurobiology, of the clinical presentations of the disease. You heard from Dr. O'Brien today that how race and ethnicity affects the presentation of the disease progression, and also response to the new emerging treatments and prevention strategies that may come across over time. It certainly helps us produce more generalizable, translatable findings, and that will be applicable to larger populations in the United States and worldwide. It will generate new information about the complex interaction that take place between social determinants of health, the AD retinopathy, and coexisting pathologies. And I think one thing to keep in mind, and I think this is being talked about in the field, that the social determinants of health, we're talking over the life course. And they really start working from the moment we are born, frankly, and they work upstream in the pathobiology of the disease. And keep in mind that many of these factors are totally addressable. We can do things about them. And perhaps when we do that, it may prevent the deposition of amyloid and tau that occurs downstream as compared to the social determinants of health. So this is how important it is, and as we learn more about this field, it'll have major impact on treatment and management of the disease, and hopefully the prevention of disease. And of course, the focus on DEI is helping us diversify our population, our cohorts nationwide, and also enrolling more people in clinical trials, which is critical. It'll help us diagnose the disease early in underrepresented groups, and also make them more accessible to healthcare services and better treatments for dementia. And finally, it'll help us improve care of people, marginalized population with dementia. So very briefly, all the presentations, Dr. Buchwald made an outstanding presentation focusing on recruitment of American Indian, Alaska Natives, Native Hawaiian, and Pacific Islanders in ADRD research. She shared that there are about 574 federally recognized tribes, but only 300 odd have reservations. She also shared that 87% of the American Indian and Native Alaskan natives, they live outside the tribal areas, and 60% of them live in metropolitan areas. The poverty rate is quite significant, 28% there, and the average income is about $43,000. The Indian Health Service has over 2,000 sites and facilities, and the budget for those services, about almost 60% of that budget comes from the federal government, but they have to generate the other 40% themselves. The per capita healthcare spending for American Indians is over $3,000, while for non-Indian population is over $8,000. So you see a discrepancy right there. The life expectancy for American Indians is 6 years shorter than non-Hispanic whites, and ApoE4 gene may not be as important in this population compared to the non-Hispanic whites. Also, the increased risk for AD in this population, many factors. One of them is poor educational attainment, and also there is a high vascular load in this population. The research participation, interestingly, it varies by the test in this population. So about 60 to 75% will agree to give the blood. About 45% will do cognitive testing, but only 9% would agree to lumbar puncture. So really the participation rate varies with what you're asking them to do. She also discussed the Strong Heart study and the PO1 supported study, which involved the brain drain events, and also there's a new U54 funded study. Some recruitment recommendations from the multiple work groups and the vignettes that they held include that make lumbar puncture optional. I think it applies to many races, not just the American Indians. That the recruitment should be initiated by American Indian community and personnel from that community. That the dissemination of information should be through the native organizations, which should be more effective. And also there was a proposal to create a registry of trial-ready participants who can go into studies as and when the right study comes along for them. The recruitment difficulties, fragmented healthcare system, the distrust toward the non-American Indian Native Alaska researchers. We don't have cognitive norms for this population. And also some myths about dementia. The other interesting thing she mentioned that, for definition of diagnosis of dementia, we need to establish physical independence, because these participants live in a multi-generational family, you may not always get the right history of physical independence as other people help them. And that's an interesting thing which may apply to other minority groups as well. Dr. Boyd, she mentioned about communicating with the elder natives, that they are the respected people, and really are the major people caring for their own family. There are some unintended consequences for negative information when you share with them, the mistrust of non-Indian, non-native healthcare workers, and some cultural beliefs about health and challenges in language translation. She also noted that the American Indian population is growing about 3 times faster than the general population. Their participation in research is very limited right now. She shared the findings of the literature review she did, and once again, there's mistrust of the academic institutions, the Western physicians, and the Western medicine. There were some concerns about data sovereignty and access, lack of knowledge about research studies, and there were some positive impacts that research participation will help the Native community, and also receiving study results is helpful for them, and the incentives of doing research study. Also, community engagement was seen as a strength by that population. In terms of research participation, 84% thought that it is important to do research, but only 51% actually were engaged or registered in research studies. Some of the key points that communication should be data-driven, using the best practices that disseminate and share research findings in culturally sensitive manner, and also evaluate the result of sharing some of the findings with these participants. Dr. Aranda, she focused on the Hispanic population and their participation in ADRD research. Their approach is to align participant referrals with active studies to focus on the micro, meso, and the macro level. You all know what those factors are. These are the barriers to recruitment of this population into research studies. And also co-design local outreach and engagement strategies and document progress and make changes as necessary. She shared the consortium that they have created in the country. There are 4 sites in San Francisco, Boston, Miami, and San Antonio, and that they are using culturally tailored recruitment strategies and planning for bilingual workforce. Also, there are outreach specialists at each of these 4 sites, and she shared some interventions as well. The lessons learned from this study, that the staff and the outreach specialists should work closely and collaborate, that the inclusion-exclusion criteria could be a hindrance to enrollment, and they should be changed over time. Also, there should be sufficient site budget. We heard multiple times how budget limitations may impair recruitment in studies or delay recruitment in studies. Also, there are some structural barriers which need to be addressed locally and nationally. Dr. Medina shared his exciting ESHCAR study, I hope I pronounced it right, which is funded through R24. And the focus of this study is epidemiology of AD. The focus is on recruitment of Hispanic and Latino community in aging research. He shared some epidemiology of AD in Hispanic population, that AD is the 6th leading cause of death in that population. And he shared the aims of the ESHCAR studies, and those aims are there on the slide. I won't go through them. There are 3 program sites, Las Vegas, Denver, and Houston, and they have the boot camp translation groups, which are very effective, about 39 people across the country, and they're involved in recruitment activities. Also, they have a community-based recruitment site, including a mobile health unit, which is helpful in recruiting participants. Some of the lessons learned: engagement takes time. We heard it multiple times. We are talking in terms of years, and it is always strengthening over time. The ADRD messaging should be culturally responsive, and the ADRD stigma has to be need a positive reinforcement, and the messaging should be family-centered. The focus should be on linguistic health and research literacy, and also balance the community needs versus the expectations from the sponsor for the study. Sometimes the sponsors may not quite understand what it takes to accomplish what they have funded you for. And Dr. O'Brien, final presentation, made it, I thought, an outstanding presentation. Focus on the ATN framework in diverse population. He stressed that although the ATN framework, the 90% of participants in ATM framework were non-Hispanic whites, and we are trying to apply it to minority population whose participation in this framework was minimal. So what we have to do is to really increase their participation in ATN studies. He shared significant data showing how race and ethnicity affects the disease biomarkers, the disease biology, the clinical presentation of the disease, the progression, and also how E4 may have less of an effect in Hispanic and African American populations. We learned that in the meeting. He has substantial numbers of amyloid and tau PET scans and over 500,000 biospecimens collected from these participants, and he shares this information broadly and widely worldwide. So really an amazing study which has more than 1,000 Mexican Americans, more than 1,000 Black and African Americans, and 1,000 non-Hispanic whites. Their age is from 30 plus. So this is truly a very distinct, unique cohort, and they are generating just very novel, innovative information. So some of the conclusions which I thought were very important, and I think they are critical for understanding the biology of the disease, that the ATN biomarkers, they differentially affect diverse populations, that the ATN-defined biomarkers are differentially related to clinical outcomes in these groups, that the clinical demographic and the socio-cultural factors are differentially related to ATN-defined cognitive outcomes in diverse groups, and that precision medicine cannot advance without diversifying our participants. So I thought his presentation was absolutely critical. Next slide, I have some not so coherent thoughts, but I wanted to hear from you all. So we heard so many times that we have to take our research to where the people are. And in literature, it's mentioned that to do that, we have to establish some community-based data collecting sites. And one of the suggestions is to involve these safety net clinics. These are federally qualified health centers. In the United States, about 30 million Americans receive their health care in FQHC, and they're all over the country. And about nearly 60% of people who go to these clinics are from underrepresented groups. So perhaps if you have some relationship in your local federally qualified clinic where the dominant population is URGs, you may have access to that population and perhaps recruit them into your study. So that is one of the sites which is in community where people go. It's close to where people live, and it is federally funded, and they exist all across the country. So perhaps we may want to think how this could be done. It is in literature, it's mentioned in literature to utilize these clinics, and if we do so, then we need NIH funding or other sources of funding, because these clinics don't have staff to collect your data. You will have to provide your own staff funded through grants who will go to these clinics, who know how to communicate with this population, who will be from that community and help you recruit people and perhaps even collect some data at these clinic sites if they have the space. So that is one of the thoughts that is, it's again in literature, but we may want to think as a field. The other thing is dementia care specialists. All the states in the country have dementia care specialists. Most of these are nurse practitioners who go to participants in their homes and take care of them, and they come to the clinics. Perhaps these are the people who may help us recruit some URG participants because they have access to that population. The other thought I had is whether you could collaborate with primary care doctors who are out there in remote areas across the country. Once again, if they have interest, that you provide the resources, you have your research team funded through your grants who go to those primary care clinic sites and start to talk to the physicians there if they could collect data at those sites. The other thought I have, which is not on the slide here, is to enhance generalizability. Perhaps we should have more international sites as a part of the ACTC trial network, or I know many of the institutions have studies going on in foreign countries, but as a field, we might want to create a network of clinical trial sites, which could be under the purview of ACTC. Again, we'll need NIH funding, or other academic institutions, hopefully in other countries, not necessarily academic institutions, but places where we could have access to population that we don't have in the United States. Once again, it'll help us generalize our findings and make it more relatable to populations worldwide. And since we are the leaders in this area of research anywhere, we need to take that leadership and ensure that our results apply to populations worldwide. And I think we may be at a time with NIH funding that we want to plan about that. So I think that's what I have as far as my own thoughts are concerned. I'd love to hear your views. And finally, the conclusions, I shared them yesterday, but I wanted to add to the conclusions from yesterday that we should really think of establishing more research sites in communities that we serve and in communities where we want to recruit the participants from. So thank you.
Well, this is the end. Nina Silverberg heard throughout the discussions yesterday and today that successful recruitment is going to take resources. You get what you pay for was a consistent theme. And she just wanted to bring attention to this group that there are diversity supplements sponsored by the NIA that might help provide some of those resources. And so thanks to all of you for your attendance. This has been a fabulous experience for all of us at the Night ADRC. We appreciate getting to know and interact with you and to hear such wonderful presentations and discussions. So I wish you all a safe journey home. Take care.